Vihang Vahia. For this session, I invite Dr. Bharat Sarode, organizing chairperson of the IPS Western Zonal Branch, who is the chair for the current conference. He is consultant psychiatrist doing private practice and has worked as class 1 psychiatrist at Regional Mental Hospital Yerwada and Yerwada Central Prison. He is the founder trustee of Geetai Humankind Trust and Astha Bahudeshya Trust, director at Astha Psychiatric Nursing Home and Smart Neuropsychiatric Clinic, and president of SMART. The second chairperson is Dr. Ninad Basde, head of scientific committee and consultant psychiatrist at Mansa and Satyak Assisted Living. I now hand it over to the chairpersons to begin the session.
So after this tea break, we are having a very wonderful session on dementia. As we know, nowadays in geriatric practice, we day in and day out see some of the patients who are showing cognitive decline. And many times these patients, they refer us after many years. And it is a growing problem, which we can say this is a dementia. And for this topic, we are having a very renowned psychiatrist from Mumbai, Dr. Vihang Vahia. So I think he needs no introduction, but still I request Dr. Ninad to introduce our today's speaker.
Thank you, sir. A warm welcome to all the delegates, as well as Vahia sir requires no introduction, but still, sir has been a teacher. He's Professor Emeritus of Psychiatry at the Cooper Medical Hospital and also a consultant psychiatrist at Rich Candy, Lilavati. He's been a DSM-5 on the DSM-5 task force and is a former chairman of the CME committee of the Indian Psychiatric Society, also the past secretary of the IPS with more than 80 publications in indexed medical journals. I now request Dr. Vahia to begin with his talk. Thank you.
Thank you very much.
Over to you, sir.
Thank you. Honorable Chairperson, Dr. Sarode and Dr. Baste, President of the IPS West Zone, members of the Executive Committee, Organizing Committee of this CME, all friends, ladies, gentlemen, and others. May I please be permitted to load my slides? Are my slides visible? Are the slides visible?
Yes, sir.
All right. So dementia 2021, I would expect that the topic would have been discussed by my late friend, colleague, compatriot, actually my neighbor in Mumbai, and he and I were born the same year. He would have been 71 10 days ago. And this presentation is dedicated to my friend, Dr. Charles Pinto. I have absolutely no conflict of interest in making this presentation. This is not a drug promotion meeting, and the only conflict of interest is I'm going to quote some of my family members in due places where the reference is merit their mention. This presentation will be in 5 parts. Let's begin with the basics. Ask 10 friends of yours, what do they mean by the word dementia? And the answers that you get could be quite frustrating. Not surprising, because there are multiple synonyms for what we lovingly call dementia. The Common English Language Dictionary defines dementia as a state of serious emotional and mental deterioration, which can be even be caused by what we call functional origin. The requirement is that it should be serious. There should be a loss of intellectual capacity and personality disintegration, all attributed to damage to the neurons in the brain, not the spinal cord, not the peripheral nerves, but neurons in the brain. The DSM-5 has given a good elaborate description of the basic requirements, diagnostic requirements for a label of dementia. Remember, nobody is congenital dementia. Nobody is born with dementia. It has to be a deterioration from previously attained level in any of the 7 cognitive domains. It should interfere with daily life activities to various degrees, requiring minor assistance to supportive care. The cognitive decline shouldn't be in the present should not be diagnosed dementia in the presence of delirium or any other psychiatric illness or mental illness that can impair cognitive decline. The importance is to remember that it is cognitive decline. There are those amongst us who do not want to trust DSM-5, particularly in tertiary institutes. For them, the ICD-11, which will be released in the month of January 2022, it also has given elaborate description of dementia. And when we compare the DSM with ICD, they more or less mirror each other. They both talk about the 7 cognitive domains, interference in daily life. According to DSM-5, it should be in the absence of delirium, whereas ICD says it should not be accountable as normal aging cognition. And the cognitive deficits should be in the absence of any other psychiatric or physical illness. But then a whole lot of our opinion leaders and academic leaders amongst our own group challenge the validity of DSM-5 and ICD. A suggestion is to look upon ICD and DSM as a language of communication amongst mental health professionals and stakeholders. When we use the diagnostic terms of ICD or DSM, we know exactly we are talking about a single phenotype presentation, not necessarily the etiological presentation. And academically, both the documents, as ICD and DSM, use an umbrella term of neurocognitive disorder. So neurocognitive disorders include dementia, delirium, amnestic, and other neurocognitive disorders. What it does not include is pseudodementia and MCI. There is a passing reference to MCI, but it is not well discussed under the rubric of neurocognitive disorders. So what is pseudodementia? Kilo coined the term in 1961, typically to describe cognitive disturbances associated with depression amongst the elderly population. Pseudodementia has 2 components, dementia and pseudo. Dementia meaning combination of cognitive deficits, and pseudo meaning not associated with neurocognitive or neurodegenerative pathology, not associated with any kind of damage to the nerves in the brain. Loosely, pseudodementia describes cognitive deficits of depression in the old age. And the symptoms are memory deficits, executive function deficits, and deficits in speech and language. Interestingly, patients of dementia, they are so forgetful that they forget that they are forgetful. When a patient of dementia is brought by the family to the psychiatrist or the neurologist for forgetfulness, most patients of dementia get irritated because they feel they are being labeled mentally sick, but they don't perceive anything wrong in themselves. It's only a person of pseudodementia who will come and request assistance to overcome forgetfulness. So when a person remember this, that a patient of dementia will be so forgetful that the person will forget that the person is forgetful. Whereas if a person remembers that the person is forgetful, and if the person is in the age range of 60 plus, you know you are dealing with a case of pseudodementia. Timely recognition prevents expensive evaluation of dementia. But the clinical puzzle is that age-related cognitive changes amongst the elderly overlap with symptoms of depression and dementia. Cognitive impairment frequently accompanies depression, and it may be so severe that it could blur distinction between depression and dementia. Neurodegenerative disorders by themselves present with depression, and depression and dementia can coexist. So the clinical acumen of the clinician and the clinical acumen or the sharpness of data collected will be able to differentiate the two. So DSM-5 criteria for depression that overlap with dementia are known to all of us. Marked slowing down in the interest of in any activity, most of the day, slowing down of thought process, fatigue, and diminished ability to think or concentrate nearly every day. Whereas the features of DSM that indicate depression is depression or depressed mood most of the day, nearly every day, and diminished interest and pleasure in all activities nearly every day. In a patient of pseudodementia, the wife would say that my husband looks lost and does not take any interest till the neighbor comes to meet us. Or the husband would say that my wife is totally listless unless she's talking to her daughter or her mother. So the patients of depression who present with symptoms similar to dementia will have phasic mood changes, and there would be periods in a day or in a week where they are totally symptom-free of any cognitive deficit. Neurocognitive symptoms of MCI, the diagnostic criteria for the frequently diagnosed clinical syndrome of MCI. As recent as last year, the Mayo Clinic published a wonderful document on mild cognitive impairment. It says it's a stage between cognitive decline of normal aging and the serious cognitive decline of dementia. It's intervening phase, and the patients of MCI will present with symptoms of problems with memory, language, thinking, or judgment without clinical impairment. I'm forgetful, I can't take a decision, but I can get on with life. Compared to patients of dementia and large number of patients of pseudodementia who cannot get on with life, MCI has no impairment. In spite of the fact that widely tested faculty continues to be the memory impairment. So, epidemiologically, 4 to 17% of the patients of MCI remain stable or even revert back after their depression or anxiety get treated. But then 83% worsens. So we cannot ignore this. And the memory decline, as a general rule, progresses from normal to MCI to Alzheimer's clinical syndrome, ACS. But memory is not the only function that we need to look at. There are subtypes of MCI. There are those with only amnestic MCI. There are those with dysexecutive or non-amnestic MCI. They only have function of the executive function impairment with completely normal memory. And this often happens in our clinical practice. But doctor, याद तो बहुत अच्छा रहता है, काम नहीं कर सकता मगर याद रहता है. That is the non-amnestic MCI. And there are multi-domain who have impairment of memory as well as impairment of executive functions. And executive functions like social inhibition, planning or decision making, and impaired activities of daily living would increase the sensitivity or the reliability of a clinical assessment. Most standalone clinicians are too busy to do this. For them, the clue, this is not a marker, but the clue is that patients of MCI will decline at subsequent, when you follow them up, there'll be a decline in their functioning, and within a year, frank symptoms of ACS will appear. And the earliest sign would be switching abilities, perseveration. When a person of MCI cannot shift from one topic to the other. And if you look at the speech, look at the carefully and the amount of variations in the speech, patients with MCI who are heading for Alzheimer's will have problems with their verbal fluency. So what are the clinical features? Now, when we talk of clinical features, what we are looking at is clinical assessment. Now, when we say clinical assessment, traditionally, we look at impairment of memory. That's all we generally, clinically, reflexly look at. And the extent of memory dysfunction helps us to differentiate the various stages of neurocognitive, that's mild, moderate, or severe neurocognitive deficits. The executive functions, which are either not tested in great details or sometimes not tested at all in standalone practice, are the ones that we really need to look at. And this is where a good clinical neuropsychologist would help a clinician to make elaborate assessment of executive functioning at the first consultation and on follow-up visits. So, neurocognitive deficit, like we said, is an umbrella term that covers dementia, delirium, and other amnestic and neurocognitive disorders. The feature is decline, not congenital, decline in cognition from earlier levels of functioning. And that it might be mild, moderate, or severe. The etiology would be any of these primary or secondary to various pathologies that we all know, we don't need to discuss today. We always look for impaired memory. We need to look at other clinical data like the origin, duration, and progress, and signs, not just the symptoms, but we should go beyond impaired memory and look at the signs. The cognitive domains are attention and processing speed, executive functions, which we all know by now, learning and memory, the new learning, simple learning and memory, the language, nominal aphasia, naming objects of requirement or daily use. We have to look at agnosia and apraxia. And most important, we need to differentiate apathy from anhedonia. Blank looks can be apathy, person is just not interested, or anhedonia, not emotionally warm, though faculties are preserved. So how do we do that? Sustained attention is the ability to ignore distractions. If I can ignore distractions, my attention is good. Or suppress inappropriate action. All of us all the time want to do things which we should not be doing. And majority amongst us are able to suppress inappropriate action. Unless you are a political leader. Then, of course, there are the speed of information and processing time taken. I take much longer now than what I did in the past. Or ability to adapt to newer situations. And this became so very important during the cognitive related lockdown and changes in the lifestyle. Working memory, the information storage in patients of dementia will be replaced by confabulations. The patients of dementia will not say, I can't remember. The patients of dementia tend, not all, but tend to fill it up with confabulations. And of course, recognizing patterns or symmetry in their work that they do. So what are the investigations? Plenty. Investigations we all have done. This is no rocket science. All of us know this all the time. We practice this all the time. If we can't do it, ours, especially neurocognitive testing, it's preferable that we get a neuropsychologist to help us out with a diagnostic assessment. And of course, the laboratory tests which are done even if you don't want the patients to do that because the internet told them. Most of our patients are internet medical graduates. So what are the biomarkers? They are not standardized. We have some reason to believe that amyloid beta, in fact, we have plenty of reason to believe that ApoE and tau proteins are the earlier markers, biomarkers of upcoming process of dementia. They are actually the gold standard for early diagnosis, but they are not widely used because they are very expensive and the technology is rather complicated. So the diagnosis of dementia or pseudodementia or MCI or any other neurocognitive deficit is purely a clinical phenomenon. Common lab tests are often requested or demanded by the relatives. CT scan or MRI with might help us in certain etiological specific observations like normal pressure hydrocephalus, for example. Neuropsychological tests at baseline and serially will help us to keep an objective tab on the progress of the disease. And there is data to say that when you have MRI results, which are borderline, not classically, what we commonly end up with a report saying age appropriate atrophy. Well, that patients of age appropriate atrophy, if their neurocognitive scores are correlated, it helps to make a sharper diagnosis of Alzheimer's dementia. The differential diagnosis is, of course, degenerative diseases, emotional disorders, depression and psychosis, metabolic disorders, especially if your patient have early onset of cognitive deficit. Look at the serum electrolytes and blood sugar as much as liver and kidney functions or any other toxins. Traumatic brain injuries sometimes get missed, and of course, the tumors and infections. Clinically, I often fall back, or not always fall back, on that mnemonic which I was told in my residency of Vietnam diet. Rule out vascular, immunological, especially in the COVID and HIV era. Ethanol, that's alcohol, trauma, nutrition, atrophy of any kind, metabolic disorders, drugs, especially antibiotics and other systemic illnesses, infections, epilepsy, and tumor. How do we manage? Well, some patients want tablets, some want procedures. Kuch bhi karo, operation karo, brain surgery karo, magar acha karo. And there are those who would rather restrict their care to tender love and care from an affectionate person. Management, the most popular is medication. When we say medication, we have three groups which temporarily improve. They only retard the progression of dementia. They do not reverse or cease the process. We have these acetylcholine esterase inhibitors, that's donepezil, rivastigmine, and galantamine. All of them, the brands, and there are generics. And there are no head-to-head comparison of the brands versus the generics, though there is significant cost difference. So personally, I tell my patients and the relatives to depend on the generic brands as respectfully as the original brands. They all boost levels of acetylcholine, which is essential for memory and learning. Primarily, acetylcholine esterase drugs, inhibitor drugs, were synthesized or promoted for Alzheimer's disease. But for the want of any other specific drug, these are the groups of drugs which are used for any kind of dementia, including Lewy body or Parkinson's dementia. These drugs have side effects which are known to all of us. Then there is memantine. Memantine also has multiple generics, and the brand is just as good as the generic. It's a glutamatergic drug. Somehow in the last 5 years, not 5 actually, more than that, glutamate is becoming the neurotransmitter, second generation, second signaling system. We started with glutamatergic antidepressant tianeptine. Then we have this glutamatergic memantine, and now we have glutamatergic endoxifen. So glutamate, second messenger system, is now getting to be more important or more focused research area. Other medications to treat sleep, hallucinations, and Parkinson's or agitation are used. Use of antipsychotics, small dose of antipsychotics in patients of dementia. This is universally black labeled. All standard guidelines say don't ever use antipsychotics in patients of dementia to control behavior. But universally, every single physician working in this segment does take or fall back on small doses of antipsychotics. Despite the theoretical universal black label, it's globally practiced to use small doses of an antipsychotic drug to control agitation or other behavioral disturbances, disruptive behaviors of patients of dementia, albeit in small doses. Personally, over the years, I have learned that use of drops of risperidone or haloperidol work out better. I don't know whether it works better, but they work out better to be able to give minimal dose without the risk of too many adverse effects. So now there is a breakthrough. There is a sudden breakthrough in the form of aducanumab AVA. This aducanumab is marketed in the US under the trade name of Aduhelm. I'm not promoting the drug, but this is something that we as psychiatrists will need to know because it's going to come to us very soon. Not from the pharmas, but our patients and the relatives are going to ask us questions about this drug. This is a drug that was processed by Biogen, marketed by Eisai. We have Eisai in India, but they have not marketed in India. And interestingly, there is something called Neurimmune, which was on the label. So I tried to look up at what is this Neurimmune. When I asked the Eisai, they didn't want to share the information. So what is Neurimmune? Neurimmune is a biopharmaceutical company that has synthesized the drug at the University of Zurich. It's the University of Zurich drug. So it's interesting. This is one example of molecular psychiatry translating into translational psychiatry, where the University of Zurich has worked at the molecular level to synthesize a drug that will work in clinical setup. So besides endoxifen, which is also a drug which was worked at the molecular level and is being now promoted for management of acute mania, we don't want to go into drugs. But this is also another drug where it was not the clinical data collected, analyzed, and then marketed as a traditional drug therapy. This is a designer drug where the molecular mechanism of dementia was studied and an agent which helps the molecular mechanism or the cellular mechanism of dementia is being addressed. So more details on neurimmune.com. On the 7th of June, 2021, just a couple of months back, Biogen and Eisai announced that the US FDA had granted accelerated approval for this drug. This is the first and the only specific Alzheimer's disease treatment, not Alzheimer's symptom treatment. Acetylcholinesterase inhibitors and memantine will treat the symptoms. This is a drug which is expected to treat the disease process. It's a monoclonal IgG1 antibody. In COVID era, we talk of monoclonal antibody cocktails so often. I received one recently myself. I hope that stops me from getting Alzheimer's. What the drug does is that it binds to amyloid beta, it reduces amyloid plaques in the brain. It has a long duration of action, hence it has to be given every 4 weeks and certainly not earlier than 3 weeks. The preclinical data has established that the drug reduces amyloid beta plaques in the brain of mildly affected dementia. So this is actually, it almost tantamounts to saying that the drug should be given to patients of MCI or maybe some pseudodementia patients or very mild dementia. At this point in time, we do not have any data on dementia of moderate or severity. So, but the fact that it can prevent the disease from occurring if given early in the disease process led to its early accelerated approval. We are still waiting for confirmatory data. And there was a news article in India on the 15th of July to say, sorry, this was not in India, but this was on FDA notification that the drug has been released in the market in the US as a prescription medicine with an FDA approved indication of mild Alzheimer's disease. So this is the first drug that has come in 20 years specifically to deal with the pathology of Alzheimer's disease. There are some controversies that the clinical trials are on a very small selected group of patients who were recently diagnosed and early in the progress of disease. We do not know once what happens if the disease is established or firmly rooted in the brain and with the plaques. And the estimated cost is $50,000 per person per year. And the company has until 2030, that's another about 9 years, to give reports for what happens when the drug is administered to persons with proven Alzheimer's of moderate or severe intensity. On the 9th of June 2021, there was an article in Indian Express in Mumbai, which said that the average wholesale cost of the drug will be $56,000 per person per year, which will be approximately at the current dollar exchange rate, be about 40 lakhs per person per year. I don't know how many of us would find our life worth that money. But the experts feel that the drug will take a year to come. There is elaborate literature on the adverse effects. There are quite a few. There is no data on renal and hepatic comorbidities. And interestingly, the company literature says that they have no data of the safety of this drug in lactating and pregnant women of Alzheimer's disease. So I don't know whether it's even likely to be a comorbidity or concurrent condition. You don't call pregnancy a morbidity. So how do we manage? What are the other therapies? The other therapies are non-drug therapies. Then there are lifestyle remedies, and the internet medical graduates always come up with data on dietary supplements, herbal remedies, and therapies. Now with the Ayush coming in, we'll also have a whole surge on non-allopathic drugs in dementia. Already people have been talking about ashwagandha and things like that. There is no convincing evidence. Time tested, yes, people over the generations have used it, but there is no scientific evidence of their efficacy, and the dietary supplements are not regulated. In fact, I have seen patients who have taken high protein, the milkshakes, and landed up with kidney damage because the dementia we don't know, but their kidney damage is the one that got them. There are other therapies for agitation and relaxation which are out of the medical books, like music therapy, light therapy. The pet therapy is becoming now people rent out their pets to soothe patients of dementia. There is this aromatherapy. Nice massage would probably work depending upon who's the masseur. And art therapy, creative abilities, all that works, but this is out of the medical books. As a doctor, as a clinician, it's most important for us to know how to reveal the diagnosis. Revealing the diagnosis of dementia is rather devastating to the family members. And we are obliged to be very clear and not give them any false hopes and mention that the disease is progressive and the prognosis about the disease. When there are only suggestions which are again out of the medical books, but then there are people always talk about it and discuss, and our patients and the relatives mention this. All these have to be person specific, and then whatever that works. If the family and the patient are happy doing any of these, well, let them do it. But most important is tell them to be a little more creative. At least that is a good memory after their eventual event. And important, it's very important for us to categorically inform the patient and the relatives to take the legal measures, letter of authority, the bank signatures and things like that, and delegate decision making to a person who they trust. Technology. There's a slight conflict of interest because Ipsit, the third generation Vahya psychiatrist, is one of the leaders. He's leading a team of McLean's that is developing technology for the care of the elderly with MIT in Boston. But I have his permission to mention a few of his papers or data from few of his papers. So the problem is geriatric psychiatry is changing. There is shortage of geriatric workforce world over. And the patients, there are fewer doctors who have lesser time, and the patients want precision and personalized but non-intrusive therapy. patients of dementia do not like to be watched over all the time. They want to be non-intrusive therapy. And the COVID has actually triggered incorporating technology in clinical care through telemedicine, for example. So what does technology do? It improves access. It improves care delivery, especially reminding the medication or adjusting the medication depending upon identifying the exacerbating factors, and it provides an ongoing support. So the pattern of use of technology amongst the senior citizens and the elderly and the patients of dementia is changing. It's interesting that the overall rate of mobile phone users amongst the older adults has grown to be more than 80%, more so in the last 2 years. When the children could not meet their parents because they were in different cities, they got their parents to use simple smart phones. And the mobile phone apps that have been developed, they produce non-intrusive observation and support to the patients of dementia and other emotional disturbances of isolated people. So there are multiple reviews on technology for diagnostics and therapeutics. In brief, the technology for diagnosis and assessment, they are important because digital phenotyping captures the subtle aspects of behavior, cognition, and mood. Ipsit often cites a case of a gentleman whose wife said that he doesn't move out of the bed. So they got him to wear a wearable, and they found that he only took 300 steps in a day. And then they found out these 300 steps were only to either go and collect the newspaper from the door or go to the washroom. When they made the person become more mobile, several of his symptoms went away. Now, this is an observation which could come because of digital phenotyping. So the patient's data that is collected through these gadgets helps the clinician to get an insight and profile the patient within the patient's natural setting without the patient feeling conscious of being monitored. Traditionally, we call this objective data from reliable source. But then the terms keep changing. So what we used to do with person-to-person observation and detailed history taking through objective data is now digital phenotyping. So digital phenotyping compared to traditional method of objective data resolves the lacuna in capturing accurate data. Patients and the relatives tell us what they think is important for us. They do not want to hide it, but they don't think it's of relevance. Whereas what they miss out as irrelevant may be of great clinical significance to us. So when we have digital phenotyping, it obviates the inaccuracies in recall of significant event or any kind of reporting bias or simply ecological inaccuracies. People don't understand what we want to know, and they would tell you what they think they want us to know. And then they might even miss out early signs. So the efficacy of digital phenotyping depends upon objective, precise, and validated methods of data collection and identifying markers of various psychiatric and neurological diseases. Continuing with technology and diagnostics, the most frequently used technology now is mobile phone apps and the GPS. The other modes are pattern of use of social media, WhatsApp or Facebook or whatever, and analysis of the language that is used by the person in social media, frequency of media posting also help to understand the person's undergoing psychopathology. There are a whole lot of variables that can be used. They can be easily implemented and the costs are coming down, and they can introduce human errors depending upon where is the variable actually worn. And probably it is the most appropriate thing to use the variable on the non-dominant wrist or put somewhere like on the thighs. There is between the MIT and the McLean Hospital, they have developed a gadget called the Emerald, which is like a tile that fixes on the wall and does all the recording and designs algorithm collected positional data of the older adults. Then there is digital and web-based neurocognitive testing. There are paper and pencil tests. There are sleep sensors and portable EEGs, and there are a whole lot of other web-based surveys. But whenever we use any of the technologies, we have to be aware of culture keepers. This is a new thing that I learned. Again, I learned it from my son, who works for the Grey Advertising. And they said that whenever you take a technology to any other country other than where it is designed, we have to be able to look at the cultural acceptance of what is done. So, what is culture keepers in healthcare? These are the people who influence the behavior and individual and the masses. And the culture keepers have a vital role in acceptance of newer knowledge and clinical practice. We saw this in vaccination. When the government came up with Covaxin and Covishield, there were people who kept saying, don't take it because it's not religious, because it is one particular political party's agenda to control the population. They are going to make people important, and a whole lot of false information was circulated by these culture keepers without being scientifically true. The culture keepers are simply any force that makes other people believe that they are the ones who bring about continuous changes and influence culture. And that influence is very, very rampant. So there is something called pharma bashing. And then there is negative media coverage, which also contributes to non-acceptance of what is scientifically otherwise a wonderful strategy and innovation. So it's important for us, when we use a technology with our patient, to explain to them its importance, its approval, its acceptance, and and if there's an opinion leader who's asking the same question, spend a little time and explain to the person. I have had people ask me whether this COVID vaccine is Jain, or whether it is a halal vaccine, or whether it is made from the serum of killed infants and things like that. It's important to resolve non-scientific or fake data being circulated by the culture keepers. So the carry home message is that DSM-5 and ICD-10 concur on the diagnostic features of neurocognitive disorders. Apart from the neurocognitive disorders, pseudodementia and MCI also present with neurocognitive deficit. And it is the extent of impairment that differentiates neurocognitive disorders from pseudodementia and MCI. And this diagnosis, or the differential diagnosis, is very, very clinical. We do not have biomarkers which are uniformly applicable. So the neuropsychological tests and neuroradiological diagnostics help us to improve our clinical evaluation. The neuropsychology and neuroradiology have gone a long way. With MRI and fMRI, we can actually see the brain connectivity and the response to stimuli in different patients. MRI correlated with cognitive scores will predict Alzheimer's disease. Traditional options of drug therapy are donepezil, rivastigmine, and galantamine. There is no head-to-head study to elicit superiority of branded products over generic brands. The reason for me to emphasize is that when family spends money on the drug therapy of somebody who's suffering from dementia in the family, the response, the expenses made and the returns that they get are never proportional. So it's morally, I feel obliged to tell the family that, well, we have to look at the cost-benefit ratio of the drug that we give. There is breakthrough drug, which is extremely expensive. We don't know how it will shape up. Technology helps us in digital phenotyping, and that might facilitate patient care. But the cultural and social acceptance of our therapy are crucial determinants of our own clinical success in standalone practice. There are some doctors working in rural areas where the doctors are treated like kind of, gospel. and they are more effective in their patient care management than some of the tertiary centers where the patients and the relatives find the doctors not gelling or not empathetic or not relating with the patient's needs. Ladies and gentlemen, thank you very much. I hope I have made a no bell presentation. The chairman probably didn't have to ring the bell to tell me to shut up. Thank you very much. Back to the chairperson, sir.
Thank you, sir. Very wonderful presentation on the very hot topic and a very common topic nowadays everyone is facing about dementia. Sir has rightly mentioned about the various definitions of dementia. He has mentioned some similarities in DSM-4 and DSM-5 and ICD-11 about the diagnosis of dementia. Then he mentioned about the neurocognitive disorders and very well mentioned the differences between pseudodementia and dementia, about the seriousness of dementia, and very well mentioned various differences in pseudodementia and dementia. And very well said that this dementia patient even forgets about their forgetting. And subtypes of dementia, then various types of the investigations, newer biomarkers, though they are not diagnostic. So he mentioned about various investigations, and the most important part about the management of dementia in a very lucid, as usual, very thorough mentioned about the dementia, its etiological factors. Acronym he has always give for remembering the students about etiology. That acronym he has given about the Vietnam diet, and again the newer technologies which will help the artificial intelligence and newer apps. They also help us in the modern medical sciences. So these were very lucid presentation. Thank you, sir, for this presentation. Now the session is open for question and answer. So I request Ninad to take questions.
Thank you, sir. Thank you for a wonderful presentation. There any questions from the audience? Okay, sir, I have a question. Dementia is a topic that I work in closely. So with the advent of these monoclonal antibodies, we do know that the earlier the diagnosis, the better we are probably placed to treat it. But still, we know that there's a huge time margin between the onset and the clinical diagnosis is made. So sometimes I do read about people speaking about screening for dementias. So what would be your opinion about it?
So this question of whether we should be screening every old elderly person above 60, for example, I'm 71, I would have gone through this screening 5 times by now. And I hope I did not give you any reason to really put me through the screening so far. Point is, what do we do? You screen a patient who's perfectly healthy, and you screen and say, look here, you are very happy now, but this is not going to last. 2 months from now or 2 years from now, you are going to be, bedridden or suffering a lot. What do we do with the result? Unless we screen the patient and we have a remedy. If we screen the patient and we find something positive and say, okay, my friend, things don't look too good, so take this so that it doesn't worsen. For example, let me give you my own example. It's normally not done. Normally, nobody gives his own example. I had fever one evening. Next day, early morning, 8 o'clock, I got my test done. I got the biofire test done. Within 4 hours, I was told I was positive. I talked to my hospital. I talked to my clinician. I was admitted in the evening, and within an hour, I was given monoclonal antibody cocktail drip. Bingo. Next day, I had mild fever. Third day onwards, I was perfectly all right. They still observed me for 10 days before sending me home. But the point is, here, screening helped. I had fever, and my RT-PCR was done with a count of 60 in CT count, and biofire immediate results and immediate treatment taken. Now, we can't possibly be putting a person who tests mild MCI or pseudo-dementing picture, and we can say, you don't look too good today, and probably you're going to deteriorate a year from now. So I'm going to put you on a treatment which will cost you $56,000 a year. Are we justified? So this is a question of more than medical science, more of social and ethical science of how much are we going to get and what are we going to do with a person who tests positive. Now, another argument that came up when we were discussing this is that if you are going to be able to make a diagnosis of normal pressure hydrocephalus just by simply seeing the way a 60-year-old person's walk has changed, a person who used to walk upright now kind of shuffles his feet or has cross-leg walk, and you do an MRI and you find a normal pressure hydrocephalus and you do, put a shunt and bingo, the guy is as good as new. How often does that happen? And how are we to, culture keepers come into the picture here. How are we going to convince people that maybe you might be having NPI, so maybe MRI will help, maybe we should, and then we should cut your brain up. Are we justified in doing that? So there are a whole lot of unanswered questions in this segment at this point in time.
Thank you, sir. And sir, again, that brings us that we should be able in a state where we diagnose it as early as possible. So what are on history and on testing, what do you think are the earliest diagnostic features we should be looking for?
So it depends upon how sharp the data, how sharp is the patient and how sharp are the family members in providing data. So when you have I don't know how to put this scientifically, but when a patient of depression doesn't look depressed and the person is 60 plus, and if there's a recent onset, patient complains of depression, but there is no evidence of no autonomic symptoms of depression, I put the patients through tests, including MRI if it is indicated. And that's where, your sharp ears, the clinician's sharpness of the ears comes into picture. So when I have a patient 60 plus who looks depressed but doesn't seem depressed on examination, I need to spend 45 to 50 minutes, ask him different kind of questions, try and make the patient laugh at some petty jokes or something that the patient remembers as funny or humorous or emotionally challenging, and see if we can provoke even dysthymic emotions. I like to see if the patient responds to emotions. And if I find the person is completely apathetic, kya fark padta hai, that kind of a thing, why should I remember? I don't want to remember. Do you remember? You don't want to remember? No, I don't even remember. Abhi aapne yaad karwaya to. These are the, especially recent events, these are the kind of patients I look at. It's a very, very subjective. It's not exactly a sensation of precox as you get with paranoid schizophrenia, but what the patient says and what the patient appears on examination, and they don't match. And if it's recent onset, if the person is about 60, well, I would put the patient, there's subtle nominal aphasia. Sometimes the patient makes a mistake. I make the patient aware of the fact that there are deficits which seem to be occurring. And if you are willing, please go through these tests. That's the way I put my patients through tests.
Thank you, sir.
Hello, I'm Dr. Kishore Gujar, sir, from Pune. Thank you for excellent presentation. I would like to ask you, whenever there is a behavioral problem like hallucination, delusion, and other issues, and you would like to start antipsychotics, specifically risperidone or olanzapine, but relative who is an internet graduate and he object for it because of it giving rise to increased risk of stroke, how to deal with such a relative?
So this is, Dr. Gujar, it is so nice. I wish I was in Pune myself. You're so right. What do we do as doctors? We advise treatment. We don't emphasize or impose treatment. Our job is to advise treatment. And for internet medical graduates questioning the doctor's acumen is a routine phenomena, at least in places like Bombay. So initially I used to get very irritated. Now I don't. I tell the patient's relatives, what percentage does this happen? And it's up to you whether you want to take that risk and treat the symptoms which are creating problems for you. If the symptoms did not bother you, you would not have brought your family member to me. So you have a patient who has these problems and we need to treat them. So The fact that you have brought the patient to me, you want to treat, and there is absolutely no medicine on the earth without side effects. So there is always, in theory, a possibility of risperidone or olanzapine, or even for that matter, quetiapine or aripiprazole, producing some other major problem. I cannot guarantee, but my experience says that it is safe. And my experience also says that if we allow the symptoms to continue, the symptoms are more devastating than the possible risk which occurs in micro minuscule number of patients. It does occur in some, but in most it doesn't. So the relatives ask me whether they can give something like a benzodiazepine. I mean, we are a benzodiazepinized society. Instead of being risperidone, if I give Restil, the patient sleeps better. Can I do that? So my answer to that is, again, the patient who have benzodiazepines, their deterioration of the memory is faster than those without benzodiazepine, and there is increased risk of risk. It's your choice. It's entirely your choice. Instead of saying, I say you do this, I say these are the options that you have. It's up to you to decide. Leave it to them, and then don't get emotional if the relatives don't listen to you.
Thank you, sir.
Thank you, sir. Any more questions? Yes, sir.
Good afternoon, sir. Thank you very much. An excellent, emphatic, excellent lecture. My question and a request would be to distinguish between culture keepers and the role of cultural psychiatry in the management of dementias, because otherwise we might get confused and do not pay attention to cultural beliefs or expectations of the patient from the treatment. If you can do that, please, or that will be enlightening. Thank you.
Sir, taking into consideration cultural beliefs and cultural expectation and cultural norms is a part of history taking. And any decent history taker, if the person has not taken into consideration what is expected out of the doctor as a part of history taking, there's a lacuna in the data collection. At the end of data collection, my first question, usually, especially in a patient of dementia or delirium, is to ask the patient and the relatives about what do you expect from me? We have to know what is it that the patient expects from you. If the patient expects that, doctor, you will perform a magic and my 80-year-old father will start behaving like a 40-year-old, it's not going to happen. But if you expect me to give something to your father so that he sleeps, or your mother, so that the person sleeps well at night, or doesn't get restless legs at night, or does not kind of, shuffle around and have an increased risk of fall because the person is not sleeping at night, or because the person gets sensory deprivation or the sundown syndrome and gets confused when you have. So then its cultural expectation is a part of the history taking. Sarvana's aso hota. This is routine. In my village, there are so many people who have this, they all do this. Well, will bhajan help? Will the Nana Nani Park culture in Mumbai, will that help? Well, these are all part of the history taking. Culture keepers are the people who contribute to acceptance of your advice. I gave you the example, the benefit of covaxin. Most people believed, but there is a segment of population, not just in India, globally, more so in the US, who are anti-vaxxers and anti-maskers. Not because they have anything else, any reason not to wear a mask or not to take vaccine, but because somebody said, this is not Jain, this is not halal, it is made out of, the infants are killed and this is made, this is government's propaganda for population control, they want to make Namaradangi in our community, things. These are the culture keepers who contribute to acceptance of your treatment. And the cultural factors is a part that will go into you deciding which is the treatment that is best suited for your patient. I hope I'm clear.
Hello. Good afternoon, sir.
Good
Very
afternoon.
nice. I don't have a question, but a simple comment. So in response to Dr. Guzar's question, the black box warning associated with this antipsychotics used in psychosis in dementia. So it gives only 1.7% of the people will have cardiac problems and death. So I think out of 100, if 2 people max are affected by such problems, it's very safer to use antipsychotics in dementia with psychosis. That's what I wanted.
So, sir, this is science. But for the internet medical graduates to accept it is culture keepers.
Any more questions? Okay, I think with that we come to the end of this excellent session. Thank you very much, sir. At the end, I would just like to add 2 notes from my end to wrap it up. Sir, nowhere did you show any signs of cognitive slowing.
Thank you. Thank you.
May you be blessed and us blessed to keep on with these presentations. Another thing, sir, that as a few of us from SMART, I think 3 years ago, we have already been part in development of an app for dementia, which has now been used by Scotland Alzheimer's. And it has been developed now in association with the University of Manchester.
Yes.
They are trying to validate the data and the points, trying to bring it up.
Thank you. I hope you share it with us in India.
It's available, sir. It's freely available as Cognicare.
Cognicare. Thank you. I'll look it up.
Thank you, sir.
Doctor, the noise level around your Cognicare is also important. If you don't make the noise, it doesn't get the culture keepers acceptance. You need to increase the noise level around what you have designed.
Yes, sir. Thank you, sir. I think with that, I hand over the mic to the podium. Thank you.
For this enlightening session and giving advice even beyond the guidelines. I now request the chairpersons to felicitate the speaker, Dr. Vihang Vahia.
Just a digital felicitation, sir, on your behalf.
Thank you.
Thank you, sir. I now request Dr. Kishore. With this, we have concluded the morning's portion of the sessions, and we can all proceed to take a lunch break. At 1:30, we'll all meet again.